started. Welcome to our August TASC 90 webinar. It was great to see many of you in June at the reverse site visit in a face-to-face setting. And today we're going to focus on financial performance improvement projects in critical access hospitals and hear from a few state projects. But we have a few updates from TASC and the Federal Office for Health Policy for their update, the regulatory update, and also Flex Monitoring Team will be doing an update. And again, you can ask questions throughout by unmuting *2, or you can put questions in the chat box on the side. Just a few updates from TASC. We will be having a Flex program workshop in October on the 19th in the afternoon through the 21st in Duluth. And that's an overview of content Flex related. The space is limited and priority is given to Flex program staff. And then any remaining spots are filled on a first come and a first served basis of other state office staff or staff supporting Flex staff. But we generally have 12 to 15 participants, so it's good for networking and meeting other states. We will be in a new location other than Fickers because the center is moving 2 weeks from tomorrow. We're just moving a mile down the lake walk closer to the bridge, if for those of you who have been here before. So still have a nice view of the lake and the ambiance of the cold for those of you who come in April sometimes and see ice. And the event space will be at an inn nearby. Also, we have coming up some tools and resources that we'll be releasing before the end of our program year. We have some leadership videos for critical access hospital administrators, boards, and physician leaders on the value transition and needs for leadership in their roles. And then a series of financial education videos, again for administrator and boards, covering 4 different topics on financial indicators, value-based purchasing concepts, and reimbursement. And these could be played during a leadership or board meeting. For Flex program specifically, we will have the program competencies for excellence guide, and we thank you for all your feedback on these competencies during the reverse site visit. And we talked about the 9 different competencies that were identified by state Flex programs and partners needed for Flex program excellence, especially moving into the new grant cycle. And then also we'll be launching a population health portal, and that's a website that includes population health tools and resources for hospitals, networks, and their communities. And finally, a CH sliding fee scale guide that explores the use of the sliding fee scale in critical access hospitals, which is required if they're participating in the National Health Service Corps loan repayment or scholarship program. And later this week, hopefully, we will be supporting FOHP and distributing the MBQIP update, including a couple of new resources that will be housed on the MBQIP website, a data submissions chart, a measures matrix with details on the fiscal year 15 measures. And then there will be a webinar on September 10th to follow up on that. So any questions about our updates? Okay. If not, I will turn it over to the Federal Office for Health Policy, Kevin Cheney and Sarah Young. Yes. star 2 to unmute, Sarah and Kevin. And
Okay, had to unmute again.
there you go, Sarah.
This is Sarah. Can you hear me?
Yes, great.
Okay, perfect. Actually, Kevin is in Michigan at the Regency meeting, so I am giving all of the updates from FORP today. He did want to send his best to everybody. As you may have heard, he is happily married and is looking forward to sharing pictures of his adventures in Glacier National Park with you next time he sees you. So the folks in Michigan may get a sneak preview of some of that in front of the rest of us. The Flex notices of award are scheduled to be coming out in the next couple of weeks. And as always, once the NOAs are issued, we will be contacting, POs will be contacting each of the states to go over terms and conditions and collect necessary materials if those are required as listed on the NOA. Some of you may get asked for updated work plans, budgets, etc. A little bit of good news for Flex. There will be a 3.3% increase in the award amount for all the grant awards because we actually had a little additional funding. So your final award number on the NOA will be a little bit more than you asked for. If that's the only change on your NOA, you will not have to do an updated budget, but some of the awards had updated budget requirements for other reasons. So just, again, read your NOA and see if it requires a budget update or not. Also, to put on everybody's calendars, the next round of grants, the SOAR guidance will be out in mid-November and due mid-January, and SHIP will be out in early December and due in early February. As a reminder, both are competing continuations this year, so they will be longer application packages. So just keep that on your calendar. And this spring, the Flex NCC will be due around March, and Kevin will be sending out a calendar with specific dates on all of those when he gets back from Michigan, probably. Finally, for PIMS, look for updates next week. You can expect a reduction in the number of questions for this reporting cycle this fall of 2015. And we are still working on what the next iteration of PIMS will be for the 2016 reporting cycle. But we expect to have a more concise collection of information coupled with using some of the already reported data like the state quality reports under NBQIP. Again, look for more information on that next week. And if you're going to be at the NRHA CAW conference in Kansas City, the end of September, keep an eye out and look Kevin up because he will be there. So that was all the program updates for Flex. Any questions? I don't see any in the chat box, and I realize you're all on mute. With that, I will go directly into the policy and regulatory update. July is always a busy season for publishing regs. Although the first one I wanted to flag for everyone is the CAW manual update that was published June 26th. This was via a letter to the survey and certification people in the states, and it has additional guidance on how state survey agencies should evaluate CAW's location and distance from other hospitals to meet the distance requirement to be a CAW. That guidance first comes out in the survey letter, and then it will be integrated in the state operations manual. The slides that went out with the meeting invitation have links to all of those resources. One thing to note, or a couple things to note, is that this clarifies the requirements for cause on islands, that if there is not a road connecting an island to another hospital, they meet the distance requirement, and that of significant help to some of our colleagues in the New Mexico, Arizona, and other areas out west, the IHS, Indian Health Service hospitals, and non-Indian Health Service hospitals will not count against each other as far as cost status goes. So that one's a pretty cost-specific update. Other than that, we have had a number of proposed and final regulations published. First, the proposed rules. The fiscal year 2016 Outpatient Prospective Payment System rule went up July 1st with comments due August 31st. And the emergency department transfer communication is probably the most interesting provision in that rule for us. They are proposing to use the EDTC measure developed by Stratus Health as a quality measure for all Medicare participating hospitals. So that could be interesting. I noticed, oh, Kim is typing a question about the previous slide on the call manual updates. Why don't you send me, if you have some specific questions about that issue, Kim, could you email that to me? In general, I don't think psychiatric rehab or long-term care hospitals are taken into consideration for CAW distance and mileage requirements, but if there's a specific issue, please contact me about it. And Benjamin asked, what's the particular reason for expanding the EDTC measure to all hospitals? And it's described further in the rule, Benjamin, and I encourage you to read it if you're interested. But in general, recognizing that that coordination of care, especially around emergency department visits, is a very important thing for high quality care and patient safety, and that it's an appropriate area to measure how care is delivered. So they identified that it was a valid and important rule and picked it up. Sarah Roberts asked about how the EDTC measure is proposed to be collected. That is beyond the scope of this update, and I'm afraid I don't actually know the precise details off the top of my head, Sarah. If you want more information again about that, would you email me and we can follow up directly? I believe it is all detailed in the proposed rule. The second big one that is out right now for public comment is the physician fee schedule proposed rule. It would make, as always, a few policy changes. The biggest ones you should be aware of are authorizing rural health clinics and federally qualified health centers to provide the chronic care management services and it was a billing structure problem why they weren't enabled to do it last year along with physicians. So this would change that. And second, requiring RHCs to report all services using HCPCS codes. There's a number of other specific changes that you can read in the slide. A number of other proposed rules with fewer direct important points for rural hospitals and flex programs. The proposed rule on the home health value-based purchasing model was published July 6th with comments due September 4th. That would apply to home health providers. A proposed rule for a comprehensive care for joint replacement model for acute care hospitals was published also at the beginning of July. Comments are due September 8th on that one, and this would make the primary hospital doing lower extremity joint replacements, primarily hip and knee replacements, accountable for all costs of care for both the surgery and rehabilitation and follow-up over the next 90 days. CAUSE would not be part of that system, but other rural hospitals in selected metropolitan statistical areas would be. A major proposed rule is revising the requirements for long-term care facilities. I believe this hasn't been done for about 20 years, so there's a lot of changes in that one. Comments are due September 14th. And then final rules published over the last couple of months. The Medicare Shared Savings Program Accountable Care Final Rule, the beginning of June. And one thing to note in this rule is it's really emphasizing two-sided risk-based models. And it did make some changes to the beneficiary assignment process so that claims provided by nurse practitioners, physician assistants, and certified nurse anesthetists will actually be counted in making patient attributions to the accountable care organization. And then, almost to the end, the 2016 Inpatient Prospective Payment System Final Rule was published at the end of July. I do want to note for folks, we've raised this as an issue before, that the worksheet S10 for uncompensated care, CMS is again signaling that they are looking at how to use that to calculate DSH payments. This doesn't impact CAUSE because they don't get Medicare DSH, but it certainly could impact other rural hospitals. And note that the Medicare Access and CHIP Reauthorization Act, MACRA, which implemented the SGR doc fix, also extended the low-volume hospital and Medicare-dependent hospital adjustments. A number of other final rules were published in July, including the Hospital Wage Index and Payment Rate Update. No, the Hospice Wage Index and Payment Rate Update. The payment rate updates for inpatient rehab facilities, inpatient psychiatric facilities, and skilled nursing facilities. There are more details about all of those in the slides. And that is everything I had as far as slides go. I noticed, John, you typed a question in the chat box too. Please do follow up directly by email if you've got more in-depth questions, and we will pull Lakina Scott in also. She can probably answer the HCPCS questions better than I can. Any other questions on that flood of regulation updates? And push *2 if you want to unmute your line and ask a question on the phone.
Thank you, Sarah, for the federal office update as well as the regulatory updates. And again, Nicole's posted Sarah's email right there in the chat box for specific questions or more details on the updates. Okay, next we'll go to John Gale from the University of Southern Maine and part of the Flex Monitoring team. And John's going to provide an update of recent projects and REASE and their upcoming projects for the new program year. John?
Thanks, Sally. What I'm going to do very briefly is I thought about mixing things up a little bit and not only talking a bit about our activities and our recent projects and new projects from the coming year, but also I think it might be helpful to start as we do these update calls, briefly talk about one of our projects so that folks get an idea of what we do. And some recent activities during the past 6 months to a year. We had a health affairs article from the folks in North Carolina and Minnesota that analyzed the proposal of distance requirements for critical access hospitals, and the findings were that it could harm high-performing CAHs in rural communities. Both Ira and I worked with the National Quality Forum on their, I'm getting ahead of myself. Minnesota worked actually with an NQF to work on the care coordination phase 3 endorsement of the Emergency Department transfer communication measures, and with CMS on the implementation. Excuse me. More accurately, Ira and I also worked with the NQF on their performance measurement issues for rural and low-volume providers. We've had briefs out on healthcare associated infections by CAHs, that it's in the works and will be out shortly as soon as review has been done by the federal office. We've released some other briefing papers and policy briefs on charity care and bad debt for CAHs. There was a follow-up brief on community benefit activities of CAHs is nearing completion. That's a sort of a complement to the charity care. UNC has been doing their modeling of the effects of the loss of cost-based reimbursement for CAHs, and they've summarized those in the finding brief. And North Carolina has been working with the U.S. Department of Agriculture and the Housing and Urban Development in their, and they're using actually the FMT financial data in their loan decision processes. So a lot of things that we do. Just as sort of an aside, between March of 2014 and March of 2015, the Flex Monitoring Team website had 34,000, almost 35,000 visits. Almost 23 were from new visitors. So people are actually finding it useful, and I'm always surprised that it gets that many hits through the course of a year. We've also worked with the Catholic Health Association on their evaluation manual for community benefit, and worked closely with the federal office on revisions to the guidance for the coming funding cycle. So, in addition to the research work and the technical assistance work we do, we end up also becoming very actively involved around critical access hospital issues at a number of levels. As I mentioned, these briefs are up on the FMT website. Our charity care and uncompensated care activities of taxes and CAHs, and then the receipt of Medicare and Medicaid EHR incentive payments. And so those are on the website if anyone needs them. Recent data reports that we've done in the past year, the National and State Hospital Compare and quality measures. We've done community benefit activities of CAHs comparing them to other urban and rural hospitals, and UNC is continuing with their individual financial reports. Now, for the fun work is the work that we're getting into for the 2015-2016 cycle. Some of it you will recognize. UNC is continuing their work on analyzing the financial and operational performance of CAHs. Minnesota continues their work on quality from Hospital Compare and Equip. And we're continuing our work on community performance benefit and charity care activities. One of the things that we're working hard to do, and it's a complicated process, is to finalize the format of the integrated CAH reports, providing data on individual hospital performance using key quality, finance, and market community measures. The reason this is a little bit challenging is that the quality data is not as easy to do as, say, finance from the cost reports or some of the community activities. But we're working, and hopefully we'll have some drafts done for discussion at some point in the fairly near future. UNC is working on quality, and Minnesota both are working on quality peer groups and refine the financial peer groups for CAHs so that they can use this information for better benchmarking. We're doing also work on identifying states with high-performing CAHs. Some of that work has already taken place at the reverse site visit, and we help identify those states with exemplary CA performance in those areas, and we'll continue to do that. And I think what's I think it will probably be of great interest to a lot of folks in the FLEX programs as we're continuing our evaluation activities. We'll be looking at the FLEX program monitoring data that states will be submitting under the new program guidance, focusing specifically on the evaluation of innovative projects and the evaluation of state EMS service data. I think that's going to be really interesting, and particularly understanding what's happening with just what the states are proposing to do under the innovative projects and what measures we can develop and work with for that. And the last is one I think is going to be an interesting challenge. We'll be looking at the characteristics of high-performing state FLEX programs, and the goal is to analyze the characteristics of high-performing FLEX programs in an actionable way so that many of us know and can probably point to some of the high-performing state FLEX programs. But what we really need to do is why are they high-performing, and what can those states that maybe are less so do about it? What can they modify and change to improve their performance? So we'll be working with Sally and others at TASC and with the office to come up with a framework. But I think this is one where we'll be reaching out and engaging the states as well. And our last project that we're doing on the community benefit side is we're analyzing a sample we'll really be looking at all of the population health and community health related reports and activities that CAHs have to do, from the community health needs assessment reports and implementation strategies that they're required to do under the ACA amendments to the IRS tax code. We'll be looking at Form 990s and really trying to get a handle on how all those things align to improve community health and the health of their populations. The goal is really to understand how well CAHs may be fulfilling their community obligations and the extent to which they can be used to monitor alignment and accountability of community health improvement activities. And so there is a question. Other than sending the financial to the CAHs, how are the financial reports used by HRSA? My understanding is it's really it's performance being used to monitor overall performance of the states. And one of the things that I think it's important to be able to do moving forward with FLEX is understand and be able to describe the impact of state FLEX grant activities. So we're also looking at, as we develop the individual reports, how can they be used to identify and target technical assistance to hospitals that may need it.
John, there's also a question from Roselia. Are CHNAs available from the IRS, or will FMT collect the reports from the hospitals or websites?
They're not available from the IRS. We'll collect them directly from CAH websites. They're required to be posted on a hospital website or a publicly available website if the hospital doesn't have one. It's about I'd hesitate to guess the numbers. I was going to say 50-50, but it's not uncommon for hospitals to report their strategy plans, but not all do, but they should be public information. So we're going to take a sample of CAHs. We won't do all 500 some odd tax-exempt hospitals, the data processing alone to do that, but we'll take a random sample and really try to hone in on them. So it'll be a bit more of a targeted project, and we will collect everything we can from the CAHs. The 990s, the CHNAs are all public information.
Okay. Thank you, John. Any other questions for John?
Well,
I'll let you finish up your slides.
Sorry, no, I have a few things. And this will be pretty quick. One of the project that we finished, and we went back and forth with the office quite a bit on this project, and I don't say that facetiously. Potentially the concern we had, and I think the office shared that concern, is the potential for people with the political climate for CAHs at the moment, concerns that people would, the policymakers might take and extract only the pieces of information that made CAHs look bad. So we really did a lot of work to try to balance that and make sure it presented a clear story. But we were able to look at charity care and bad debt performance for CAHs compared to other hospitals. And the reason this is really important is the the community benefit activities aside, the essential community service that most community benefit activity that most policymakers look at is charity care. And so we were able to do a pre-baseline analysis of the data, and we will revisit this again, but this was before the ACA mandated financial changes. And so I'll go over some quick key terms. Charity care. Charity care is free or discounted care delivered to patients with a demonstrated inability to pay, and that's based on hospital financial assistance policies. Bad debt is something different. Bad debt is a condition of doing business. They're write-offs for services provided to patients who have an ability to pay, but later refuse to do so. And they're a bit of a challenge for hospitals, and we'll get into that in a moment. Even though they're two separate conceptual categories, they really are points on the continuum because they're influenced by hospital policies, revenue cycle management, how well the hospital is able to collect. And I think it's important to look at because as we jump into as we get into this a little bit, you'll see why that's an issue. But the policy context is that as I mentioned, this is an important part of community benefit activities. The ACA in 2010 mandated changes to the IRS tax code requiring tax-exempt hospitals to have established written policies for financial assistance in emergency care. Here, to date, that's not a requirement. So while some hospitals may have policies, they're a bit informal. And when they're informal, it also means they're inconsistently enforced, and they're hard for patients to find out about. They have to limit charges for medical care provided to financial assistance patients. At one time, the only patients that were ever expected to pay full charges were those that didn't have any money.
You don't rush them along.
And then they're also being asked to refrain from extraordinary billing and collection efforts unless they've made reasonable efforts to determine patient eligibility. It's another issue that hospitals have received a lot of flack from, is the aggressiveness of billing policy. So our findings. If you look at total uncompensated care, combined charity care and bad debt, CAHs report fairly high rates of combined total uncompensated care at 7.4% of expenses compared to other rural at 5.9% and urban hospitals at 5.1%. They report the lowest rate, lower rates of charity care compared to other urban and rural hospitals. They're also more likely to adopt restrictive eligibility criteria and use lower multiples of the federal poverty guidelines. And finally, they're less likely to provide free or discounted care to medically indigent patients than other hospitals. Now, medically indigent patients are those who may have the ability to pay for some of their care, but because of the severity of their illnesses or the relatively low payment rates by their insurance plans, even though they have the resources, the total volume of their costs overwhelm their ability to pay. And they normally don't meet financial assistance guidelines. They may have a reasonable income, but their expenses are beyond what they can pay. CAHs report higher rates of bad debt than other hospitals too. They're less likely to have written charity care policies and report their bad debt in accordance with the HFMA, Healthcare Financial Management Association Statement 15. So, and then finally, the IRS is looking at the hospital industry has made an argument that some percentage of bad debt is likely to be attributable to charity care for reasons such as patients don't apply, they fall through the cracks, and so that some portion of their bad debt should be attributed to charity care and community benefit for purposes of justifying their tax exemptions. Now, the IRS isn't necessarily buying that, so they've asked hospitals to estimate what that percentage is and justify it. And it's interesting that CAH has reported a lower, by a fair amount, 10.5% compared to 17.6% and 18% for other rural and urban hospitals. And what this all means is I think that there is really a need for hospitals to begin to analyze their charity care and financial assistance policies. I don't think it's true, and the concern is that some people might look at the lower levels of charity care and say they're not fulfilling their community obligation. I think there's a lot of work that needs to be done around understanding what's happening between charity care and bad debt. So the first recommendation of CAH is really begin to analyze who falls in what bucket. So if, for example, patients with incomes at or near slightly above the hospital's eligibility criteria constitute a lot of the people in that bad debt bucket, then they've got to think about what they're doing. Should they revise their financial assistance policies to reflect the economic status of their patient populations? Maybe expand eligibility, make it more, and promote it more heavily. If people in the bad debt bucket are low-income patients that would otherwise qualify for charity care, they need to think about revising the application process, making people more aware of it, simplifying the eligibility criteria, and improving the screening process to identify those patients that might be eligible for public insurance coverage or other financial assistance. I mean, this is really, I think, certainly not in every case, but the discrepancy between charity care and bad debt for CAHs is that I think some hospitals view being a good steward of their funds, but they are probably too restrictive and maybe not always reflecting the needs of their communities. So other strategies, if some of these patients are low-income patients for the working poor with high out-of-pocket costs, is maybe make it easier for them to get access. One standard that often excludes patients from eligibility for charity care is having health insurance. Now, we know under some of the plans available under the marketplaces, they may have insurance coverage, but they have substantially high out-of-pocket costs. And if they're low income with a large family and a $10,000 or more out-of-pocket costs, they can be functionally uninsured for that out-of-pocket. So that may be some of the bad debt problems. Improving screening and revising billing systems to capture charity care at different stages of the billing process. So I think that what we're seeing is that there's a need to really sort of step back and understand what are the component parts of those and who's being affected by charity care and bad debt, and maybe help to align the findings over time and the results so that CAHs are actually reporting more accurately. And finally, we also think that in terms of community benefit, that there are other strategies that hospitals can use to manage charity care and improve access. We mentioned revising the policies to reduce financial barriers to care for vulnerable patients, and also revise the financial assistance programs to ensure patient access. Is need to provide culturally and linguistically sensitive assistance with charity care applications, improve awareness of financial assistance programs among vulnerable populations. These hospitals do have, as a tax-exempt facility, an obligation to provide these services, but I think oftentimes, and it's not just with CAHs, that information and that availability is inconsistently available to different populations. Adapting population health strategies can also help to improve access. encouraging early intervention in health programs, reducing unnecessary utilization of high-cost inpatient care and emergency services by expanding access to primary care and other essential services, doing care management, providing wellness, preventive and chronic care services, and assisting in overcoming travel barriers. And I think that's it.
Thank you, John. And
You're
thank
welcome.
you for the How Charity Care Performance in-depth look at that study, and interesting to look at it overall since the CHs have a greater level of total uncompensated care, and appreciate those strategies. Any questions for John? You can start to unmute or put that in the chat box. Okay, hearing none. Thank you, John.
You're welcome.
We'll move on to the financial project for critical access hospitals. And the first one we'll be hearing from is the Kansas Critical Access Project. And this was a revenue cycle consultation. And our speakers for Kansas are Sarah Roberts. And Sarah's the Director of Primary Care and Rural Health for the Bureau of Community Health Systems within the Kansas Department of Health and Environment. And Sarah joined that department in November 2010. Prior to that, she worked in the Department of Health Services Research and Administration at the University of Nebraska Medical Center. And Kansas has 84 critical access hospitals, and Sarah oversees Flex in the state office and also the PCO. And the other speaker for Kansas is Rhonda Barkus, and Rhonda is a program specialist at the Center in Rural Health Innovations, and she's worked primarily on the Small Rural Hospital Transitions project, and prior to that, the Rural Hospital Performance Improvement Project in the Mississippi Delta area. And she's been assisting the state office and working as a liaison between the critical access hospitals in Kansas and the financial consultant. And Rhonda developed the Recommendation Adoption Progress Reporting Process, or RAP, and that is focused on gathering and analyzing project outcome data. And they'll be talking about how they're doing it in Kansas. So I'll turn it over to Rhonda and Sarah, and we'll go about 20 minutes, and then I'll introduce our next speakers from Georgia.
Great.
And Sarah, Rhonda, yep, we can hear you. Go ahead.
Great.
Yep.
Well, let me ask real quick, Brinkman, am I to control the slide deck, or are you wanting to control the slide deck?
You can go ahead and control the slide deck.
No, I don't.
Yep, just the arrows at the bottom there.
Thank you. I saw that. Thank you. So this project, as mentioned, was done in collaboration with the National Health Resource Center, and this is a funded project through our Flex grant. As Sally mentioned, we have 84 critical access hospitals in Kansas. That has changed to recently. We used to have 93. So for our brief kind of 20 minutes, here's some agenda that Rhonda and I set out. And so we'll go very quickly through the first several bullets in hopes to give more time to discuss what we've learned so far and our lessons learned and our next steps. The slide deck has a lot of information in the first few slides, and I'm just going to highlight those things and then allowing you time to look at ever more detail if you are really interested in learning about the design of the program. So just a glimpse for folks to understand, with 84 critical access hospitals, one thing that is very relevant or observed in the last several years is when you look at our performance measures, the Flex monitoring ones, we tend to have the more mid-high, high-risk hospitals in this group than other critical access hospitals across the United States or other states. So you can see with about at least a quarter or a third of our hospitals falling into that mid-high, high risk area. So with that occurring, we were spurred by the federal office to begin looking at what is the understanding, what is going on with our Kansas financial situation, and what could be effective strategies for us to use through the Flex grant. Prior to that, this started kind of in the early 2012, and prior to that, our focus around financial really was education. We did a large amount of education and realizing that we may have to look at something more intense and targeted. So over a series of months, we met with the Flex, we asked questions of our experts in the Flex monitoring team with George Pink. We asked TASC and folks to what would be their observations and strategies. We landed on the need for revenue cycle management. That really was based on the resources and activities that are currently going on here in Kansas, and again was the most effective. So in earlier that 2012 and 13, we started with, okay, let's do a statewide assessment. We worked with other partners, those from Nevada, to do that assessment, and then we began to build our sort of request to have a more multi-hospital project. So by early 2014, we end up identifying that the best way to carry this project out was working with the National Rural Health Resource Center. So you can see how it did take us some time to kind of identify and plan. The biggest challenge, I would say, for us in planning wasn't necessarily identifying the strategy or the means for doing it. It was how do we make this work with the resources we had available and get and reach as many hospitals as possible. So, you know, trying to reach 8 hospitals in each year was quite a bit of a task. That was our goal, and trying to find a design that would meet that resource limitation. So here's the project that was designed. Essentially, our hospitals, our objective was to get a high-level assessment of the revenue cycle process in the hospitals and give them essentially a report that gives them best practice recommendations so that they could go on and implement those activities or strategies inside their hospital. We really wanted to hone in that the hospital had to participate, so we designed or mirrored the national model and said the hospital had to commit some participation requirements to this. As you can see, we had expectations for the CEOs, and we had general expectations for the hospital. So when we identified the hospitals, we really looked at those that were the greatest need. We used the Flex monitoring indicators, and I developed essentially a composite score for better luck and used the benchmarking information that was provided by Flex, but we also developed a little bit of our own numbers, and I'll tell you the reason for doing that was when you looked at just the benchmark numbers, if you looked at the slide 2, you'll notice that we had a lot of them who weren't meeting those benchmarks. So we needed to figure out a way to scale down our target area a little bit more. So you can see here, just essentially made a very simple composite score, and if the hospital met it in each year, they got a point, and if they didn't, they got 0. And basically looked at an average score across the years. And then, so all hospitals that received an average score of below 4 or 5 points were targeted in the recruitment. And because of our resources, we had to be very mindful of traveling. So just for that that purpose, we divide Kansas into 2 quartiles. Cohort 1 was southern part of Kansas, cohort 2, northern part of Kansas. And that was really, again, needing to think about our consultant and her time for traveling. Traveling from southwest Kansas to northwest Kansas in one trip would not be doable, where you could go from the east side to the west side of southern Kansas fairly a little bit more easier than the other way. So once we went through the recruitment process, we began with recruiting the hospitals. We sent out emails. We reminded those hospitals of our emails, and we made it very clear they had to sign a basic one-form participation that really told them, yes, we're agreeing to participate in this project, and we're agreeing to do the expectations that we had outlined. This was a free program to the hospitals. So we felt that they need to be committing of their time and investment because it was a very resource-intense project. Once they recruited, we went through with a process, and you can see here it started with first a kickoff webinar. All the hospitals in the cohort joined the webinar, and we outlined the project, timeline, and the requirements for compiling data. Before the consultant would complete her assessment, we knew we needed the hospital to provide as much information up front that she could look at and review before the site visit. Then the hospital had a pre-on-site phone interview with the hospital and the consultant. This mimics the model of the national Delta, the Delta region rural hospital performance improvement. So this part of the process really does mirror that national initiative. Once the interviews were done, then each hospital received a one-day site visit from the consultant. And that hospital leadership and the frontline managers were involved, and that consultant essentially came in and asked, so tell me how you do, and they walked through the process. Once the consultant was done with her visits, she would create a report. And at some point, the hospitals received that report and again have another post-project phone call with the hospital and the consultant. For us as a program, we also wanted some information. So what we asked for it was to do a post-webinar with the entire group because we wanted them to hear that there are common needs across the board. You know, you always hear some of the statements that each hospital is unique and has different issues arising. And I certainly agree that each community has its unique characteristics, but many of these challenges that we're seeing with the revenue cycle are we're very similar across all the hospitals that participate in that cohort. And so we wanted them to kind of hear what the results were as a group and to see that we really were looking at it as for next steps. So here's the general timeline from starting last summer to where we are now with the project. And you can see we did a cohort of 8 in last summer. We did a cohort of 7 this past spring. Part of the process then afterwards is that we're using the recommendation adoption and progress framework that Rhonda has created. Typically in that model right now you'd wait 12 months to follow up with the hospitals. So we're making a little bit of modification because we want to know now what's going on. So we added a 6-month post-project check, which is going on as we speak. The second thing we also learned based on those webinars is we developed a small learning community project after the assessments were done to help the hospitals focus on how do you develop and utilize your revenue cycle management teams. So they were able to get access, a very defined time of remote access to the consultant to talk about their management team and reviewing charts. How do you review your charts? What are they missing? So I'll stop there because I believe the next part will be talking about the RAP process. I believe we probably will hold questions to the end. So Rhonda, I'll let you take it away.
Okay. Can everybody hear me okay?
Yep, thanks, Brenda. Go ahead.
Okay, good. So I just wanted to talk a little bit about some of the general findings that were discovered as part of the data, looking at the data, looking at the pre-project data, and then also the on-site projects. So as we started pulling all of it together, I think that maybe we should not have been surprised, but I think we were all a little surprised at how very, very similar the findings were for many of the hospitals. I think we all expected there to be a lot more variability in some of the issues, but we were seeing very similar issues for almost every hospital, which the positive thing, which Sarah will talk about in a moment too, is it helped her to create kind of the follow-up. So instead of having to do some sort of a shotgun education for hospitals and try to hit a lot of different needs, many of the hospitals had the exact same needs. The very first one, which was key and it was core for every single hospital, is that they did not have a revenue cycle team. Often they had one person from the business office who was trying to drive the revenue cycle improvement. And we all know that that doesn't work very well because it is a collaboration among many different departments to really be successful at a really good revenue cycle process. The other main themes that we saw is for the pre-admission and the admissions process for inpatient, outpatient, and emergency departments. They were all lacking any kind of patient insurance verification during registration. There was often very minimal pre-registration processes, and also a lack of upfront collection processes. Because they weren't doing a lot of pre-certification when they could for different kinds of treatments, the denial rates ended up being pretty high. There wasn't a lot of checks and balances to make sure that the charge capture was correct, revenue codes, units, modifiers, that all of those things were correct. Also, one of the other main things that the consultant found is that all of the hospitals were very frequently using nurses to register patients, and I know the hospitals thought that this was a way to kind of make the most of their staff, but what it ended up doing is resulting in high salary staff doing basically administrative work. And the other thing is because those nurses did not report specifically to the business office manager, they weren't getting a lot of times the same training or the laser focus on things like upfront collections or the different registration regulatory changes such as the Medicare secondary payer. And there wasn't as much kind of buy-in maybe to doing a very, very full and complete registration process. So that was another huge finding. And then there also, for many of the hospitals, there were issues with the transparency and communication, patients not knowing up front what their copays were going to be, not being prepared for those copays, no advanced beneficiary notices being completed. So several findings among all of the hospitals. So those were some of the main findings. As Sarah mentioned, we are just beginning to look at the outcomes from cohort 1. So those were folks that finished their project back in December 2014, January 2015. And so we really wanted to see how they were doing on their implementation. And so that, like I said, that just started last week with some of the first RAP follow-ups, and so I've actually done 2 so far, so I just wanted to talk a little bit about the early findings. So the RAP process really takes a look at 3 different areas with the hospital as far as looking at outcomes. We talk a lot about the progress on their implementation, so that's kind of the opportunity for them to tell the story of what all the things they have done so far to implement the recommendations. Then we take a look at the data and begin talking about that. And then we also talk a little bit about the impact of this project on the hospital. So the RAP interviews are at least 30-minute conversations with usually the team. Sometimes it's just a couple folks, sometimes it's the full team. And we really look at the details of the things that they've already implemented. And so sometimes that's just some changes in policy and procedure. Very often they were talking about beginning to really focus on upfront collections, streamlining their pre-registration process. So we just go into detail. So we don't just say, you know, if they're talking about their point of service collection, they don't just say, oh, we're working on that. We really go into detail. What have you been doing to really work on the point of service collection? So that's the progress part. And then the data part, prior to the project starting, we looked at the KPIs that were suggested by the Flex monitoring team, and we got some pre-project data, and we'll be looking at post-project data. But also in this interview that I do with the hospitals, I want to know what other data are they looking at, which might show some progress on those more short-term kinds of goals. And so we're looking at things like, and the data that they're looking at for this really is going to depend on what they're really implementing, what kinds of recommendations they're implementing and focusing on. So for instance, some of the things that they're talking about so far is looking at their gross accounts receivable days or their point of service collections and looking to maximize that, the dates to close. And so just based on these two hospitals that I had interviewed this past week, one of them mentioned that their gross AR days has already decreased from 62 to 48, and their days to close is moving in the right direction from 9.2 days to 8.2 days, just that they've been implementing recommendations. The other one mentioned that they've noticed an increase in point of service collections, and they're still pulling that data to send to me, and I'll get that next week. So it's really pleased that they were already able to identify some data. Also, both hospitals, I asked them on a scale of 1 to 5, to what extent have they actually implemented the recommendation? 1 meaning nothing's been implemented, a 5 meaning everything has been implemented. And one hospital said they would say about a 2.5 right now. The other said 3. So that's pretty right on target where we would expect them to be just 6, 7, 8 months down the road. Then the last question I always ask them about is the impact of this project on the hospital. This is important because in addition to the measurable data and the things that they've done, I think this really speaks to the cultural change, because that will be what helps to sustain the changes from this project. And so both hospitals talked about there is so much more communication among the departments and so much more accountability and ownership for all the departments that are involved in revenue cycle, not just the business office, but it's also the clinical folks who are really understanding their part in all of this. And then in November, December, I will be following up and doing a second RAP interview on these same hospitals, again, just to see what they continue to do to implement and then to look at that measurable data. The nice thing about doing this first RAP interview is this is going to help to keep them moving forward since they know a second interview will be coming later. And then just to speak a little bit about lessons learned, it is always about the leadership, and you guys know that there were times when, you know, as the consultant went in, she discovered that there were issues with the leadership team in general, and that if some of those weren't addressed, then the project might be very difficult to implement, even with the best of recommendations. And so then we had to kind of look at, well, what were some other resources or training ideas we could share with those hospitals to help them move through that piece so that this project could be successful. Some things I think that we did do, which for this project we did well, which helped, is we were very clear with the hospitals up front what the expectations were, what the timeline was for the deliverables, and we kept the hospitals engaged because we had a pretty aggressive timeline for this, like maybe really, I guess about 4 months from beginning to end, and I think that aggressive timeline pushed hospitals to stay engaged. I think if months had gone by between pieces that Sarah mentioned earlier, like webinars or on-site visits, people could have disengaged, but they didn't. The last thing that we did discover from that first cohort is they were so interested in knowing, well, what's next? What's next? They were asking the consultant, okay, after our report, then what? So that's what our lesson learned for cohort 2 was we really needed to already have a plan of how we were going to support them moving forward after their report arrived. And so that is when we already put into place the idea of having the learning community set up so that they knew that there was more support coming to help them to implement the recommendation. So I want to just turn it back over to Sarah for a moment so she can speak a little bit about how she's using these results to look at the future of her activities. Sarah?
Great. I'll keep this pretty brief so I know that there's other presentations behind us. So really what has happened is it has changed my thought and planning for the future. When we wrote the Flex grant, we were just starting the second round. And so I had decided that based on what we had done so far, that we would do a third round in our next year because we were going to target the really high risk folks. But after looking at the findings this past year and what, as Rhonda had outlined, it's changed my focus to now developing what I think will be a robust education plan that's not just let's just have a webinar, let's have a workshop, but really interactive workshops. So, for example, this revenue cycle management team piece seems to be continuously a key element to any success of the project or revenue management. And moreover, when we learn from the learning communities, what our hospitals are doing is they're reviewing charts, but for the survey compliance perspective and not from a revenue cycle charge perspective. So I'm looking to how can we design something available that really gets them involved. So it's like, is it a workshop where they come, bring a chart, and we go through it and discuss how you do it? Or do we focus on certain type of coding that was prevalent as a need across the state? So it's been very helpful for me in rethinking, because had we had very unique issues, I would have said let's continue the assessment. Now that we have a very common trend across all of them, I've now identified that it's better to do more of a focus more on the education, the next steps, the learning community piece of it.
Great, thanks Sarah and Rhonda. And their contact information, I know they have on the next slide as well. And we're going to take questions after the second presentation by Georgia. So if you have something from Kansas, go ahead and put that in the chat box so we don't lose it. You don't forget the thought. And again, their information's up there. Thank you both. Well, now we have a presentation on the Georgia Financial Performance Improvement Project, again looking at revenue cycle. And we anticipate having Patsy Whaley, the director of the Georgia State Office of Rural Health, but just at the last minute, Patsy was unable to join us. So Cindy Dupree, who is planning to present with them, and their consultant for their financial improvement projects, she'll be presenting. And Cindy is a partner with Drafton and Tucker's Audit and Accounting Service Group in Atlanta. She focuses on the healthcare industry. And Cindy has more than 40 years of accounting experience working with audits, 340B program assessments, community health needs assessments, community benefit planning, and revenue cycle improvement. And she is a certified public accountant, and she's worked on numerous operational and reimbursement projects. So Cindy, I'll let you take it away, and you can control your slides with the arrows at the bottom.
Okay, thank you. Can you hear me okay?
Yeah, you're loud and clear. Thanks, Cindy.
Great, great. Okay, what I was going to talk about is the last phase of a project that we have been having in Georgia through the Flex funding, and it's been pretty much a 9-year project. The first 3 years we performed what we call the fiscal analysis of the critical access hospitals in Georgia, just pretty much trying to understand what their financial position was. The next 3-year Flex project was focused mainly on education. It was a really intense 2-day on-site educational programs talking about everything from the cost report to the revenue cycle to the ACAs, the future of critical access hospitals, etc. And these last 3 years, we have focused a lot on the revenue cycle, focusing mainly on accountability of the hospitals in performing as well as they could in the revenue cycle process. Now, under this grant, there's 10 areas that we met under this grant, so you can see it's a pretty robust and aggressive program that we had. The first was we were going to analyze the revenue cycles. We were going to conduct SWOT analyses, identify opportunities for improvement, develop action and accountability plans, conduct quarterly assessments and monitoring, and all that was related to the revenue cycle. We also had a component related to their cost reports where we saw there may be issues there, doing some limited charge description master work, reporting financial measures, just evaluating some things surrounding PPS, and to refer provider recruitment needs to the state office. Now, we started with 33, we have 33 rural health critical access hospitals here in the state of Georgia. 28 signed on to participate in this project. When we finished, there were 16 at the end of the 3-year cycle, which ends this month, that continued to participate. And what we found out, some of the challenges were, some of these critical access hospitals were looking for a quick fix. They wanted somebody to come in and fix their problems rather than having some long-term actions that they would input to fix those. Some felt like there was just too much to track. You know, under these federal grants, we have a lot of measures, and a lot of them dropped out because they said, we just don't want to have to deal with all these measures that we're now having to deal with. Some said they were too busy, and many of the hospitals dropped out because of changes in their operating structure. Some were purchased, one closed, some went with a larger system that had a central business office. So there were a variety of reasons as to why, where we started out with 28, we ended up with 16 in the hospitals. Now, our focus was on hospitals improving from within. We were not trying to sell them software, sell them more consulting services. It was, let's analyze what you have and how we can improve on what you have. And I mentioned we started with the SWOT analysis, and we had a 35-page quality assessment that we performed for each of these hospitals. And in this, it was a very detailed questionnaire that was sent to each hospital, looking at each process through the revenue cycle from registration all the way through collection. The screenshots you see here are samples from our charge capture and our medical records or HIM areas, where we would ask them, here are some critical questions that we think would be good processes to have a good revenue cycle process going. And when these were returned to us, we color-coded them, whether we felt it was a strength, a weakness, or an opportunity or a threat, that then we could discuss during our on-site meetings. And we had a 3-day on-site meeting at each of these hospitals. And during these meetings, we would discuss based upon this assessment, and then also we had discussions with the entire revenue cycle team. We would identify in each area, and like this screenshot, for instance, registration and claim submission, what the strengths were that were in their revenue cycle and where there were weaknesses. And as we heard in the previous presentation, there was a lot of commonalities among these hospitals. Many of them used the same software and were having the same issues with their software. And at that point, then, we got a group to just call the software vendors to say, hey, we're having common problems here. Can you work with us on trying to take care of these problems and see what we could get out of these problems? But we looked at the strengths and the weaknesses, and based on the strengths and weaknesses, then we developed specific action and accountability plans for each of the hospitals. And one of the things you're going to see is, as we quickly go through here, there are a lot of measures that at the national level, at the HRSA level, they're discussed that need to be looked at to determine the success of the program. And I personally have been very vocal that I don't agree with these measures because I think they're too broad. And for instance, if you look at days in AR, there are a lot of variables that affect days in AR. And we may put in an action item that you will see, may be a successful action item, but if we only use the measure days in AR, we cannot really measure that success. So for each of these hospitals, when we did their action accountability plans, we developed specific goals and specific measurements that we were using for these projects. No two hospitals had the same action accountability plan nor the same measures in doing this. Now, the way we started is we started out thinking we were going to do 8 to 9 hospitals per year, and we quickly found out that this type work is not conducive to doing that because the problem is the hospitals that end up in the 3rd year of the grant, they really do not get the attention that the hospitals that were in the 1st year of the grant received. So we switched up a little bit on how we particularly did those hospitals. Now, everything that we did, it was all, as I said, focused on accountability. And each hospital, once we finished with their on-site work and we had developed their action and accountability plan, there was follow-up monitoring. And maybe we don't trust our hospitals as much as Rhonda trusts hers, but we sent quarterly monitoring reports. In each of these cases, each hospital had to collect data on spreadsheets and send those spreadsheets to our office. We would take that information, we would develop graphical depictions of how they were doing. We would send these back to them with questions, say, explain to us why, for instance, this registration error rate changed. Explain to us what's going on, what happened. And this information was sent to the hospital CEOs and to the revenue cycle committees for them to review and to respond back to us. When I talked about specific measures, this particular hospital was having an issue because they were not tracking registration errors, which could ultimately affect accounts receivable. So instead of looking at days in AR, we said we want to see what your registration error rate is. So start tracking the number of errors by registrar. Set a goal. Their baseline when we started, their error rate was 21.7%, and as of January 15th, it was down to 11.6%. Just another quick example was charge capture. A lot of the hospitals were having problems in the ER of having errors in their charting errors. So in this particular instance, this hospital was having problems with charting errors, and they were having like a 56% error rate, and this was counting any type of error that they had. So they were elected to monitor those errors using specific charge capture error forms to show what they would treat as errors and see if they could get that reduced. We had a lot of issues in medical records with physician deficiencies, not getting charts out. This particular hospital here said we're going to chart physician deficiencies, and we're going to see if we can get these days down, delinquent chart days down. So they were particularly looking at this area. Claims follow-up. We had some issues on hospitals that were not appropriately working their claims on a timely basis. So in this particular instance here, in order to hold the staff more accountable, they developed actually tracking of claims by the clerk to say how many claims have you worked versus the total number of claims that are greater than 30 days, and let's start looking at this and monitoring this. So I see the last one, AR days. We did monitor AR days to see if all of these actions were helping in some way. Collections, point of service collections, actual dollars collected, that was a pretty much common through all the hospitals that we looked at. So most of them said we're going to set collection goals and we're going to start tracking this by collector to see how much money we can collect and start improving. So that's just a very fast summary of a lot of work that we did among these hospitals, trying to get very specific measures that they could track, they could monitor. But I think, one of the big differences in what we did is requiring them to send that data to us. Now, in the last 3 months, we have visited all of these hospitals, all 16 of them, in the last 3 months, doing on-site follow-up, meeting with the groups to determine, going over their quarterly reports with them in person and determining how successful it's been. And at the very end, I'll give you some of the comments that we've had. Charge Description Master, we did a limited review on those, just a quick screenshot of some of the reports. This is an example of one of the reports. Some of the things that we found were very common is that a lot of the CPT code, HCPT codes were invalid, and so we sent back electronic reports to all the hospitals after we reviewed their CDMs, and we probably reviewed over 20 of the CDMs. We had more participation there, but showing them what codes were invalid. We gave them very extensive reports of all the items in their charge master that had codes on them that they could use with their department heads to compare what the actual code description was to what they were doing to make sure that was correct. Did extensive look at the Medicare cost reports, trying to find common issues. John talked earlier about some of the S10. That was one of the issues that we saw in a lot of the reports, is the way that the charity was reported on S10. And as a matter of fact, I think there's a SHIP project that has come out of that now here in the state to work with these hospitals on the S10s and to make sure that data is properly reported. We had about 20 different things on the cost report that we saw. One of the common ones was emergency room availability in critical access hospitals, not correctly reporting that, not having the contracts to support those claims, incorrect wording, not having time studies. And one of the last things that we looked at was the key performance indicators from the reports that John was talking about earlier from the Flex monitoring team. And what we did here is we tried to explain to our 16 active participating hospitals how the Flex monitoring team reports worked, where they came from, and what was surprising to us, 2/3 of these hospitals were unaware of the Flex monitoring team work in their reports. And Patsy and I talked a good bit about this. She had sent information, to the hospitals about these reports are available, but for some reason it is not getting to the right people. And I know Patsy's talked to John or Dr. Pink about this, but for some reason it's not getting to these hospitals. It's not getting to the right people so they can look at this information. So we wanted to spend time when we did these on-site meetings in the last 3 months to look at these Flex monitoring reports, to educate the hospitals about them and the availability and what the data means. Now, what was interesting, out of our 16 participants we had, they fell in 12 different peer groups, and that once again shows you how different all of these critical access hospitals are in the state. We took the data that was in the Flex monitoring reports, this particular report. We updated it for all of the hospitals based on their 2014 cost report information, using the tool that was on the Flex monitoring team website to make sure we had comparability between the reported values and the updated values. We compared what they were doing now to what they had been doing before, were they meeting their benchmarks or not. And just as a note to let you know, the feedback that we got from many of these hospitals was, why are the same benchmarks used for all peer groups? Why are there not separate benchmarks for each peer group because as we looked at in Kansas, you could see most of those Kansas or a lot of those Kansas hospitals were not meeting the state or their peer group benchmarks. So that was just one of the questions, just as a note to the Flex monitoring team, is there is a question about why are there not benchmarks for specific peer groups than having the same benchmark for all peer groups. We had a lot of discussion about benchmarks when we were doing this, about not just looking at one benchmark and trying to determine if you were doing good or doing bad, or if management was doing good or bad, but that you need to understand the stories behind those benchmarks. Another thing we saw quickly is the benchmarks are coming from the Medicare cost reports, and sometimes, especially in the area of accounts receivable, the benchmarks data that's coming off the cost reports bear little resemblance to the days in AR that we see on the financial statements. And I don't know if it's when the cost reports are prepared that there's just not a lot of care taken with that information when it's put on those schedules. But we did have a big difference between what this report was showing versus what they actually had in their audited financial statements. We discussed plans for future sustainability, and during this 3-year period, it was really surprising the changes that we saw in the hospitals over the 3 years. Several hospitals, when we met with them in the last 3 months, are either in discussions to be acquired or to be leased or to be managed by other facilities. We met with one hospital on a Friday that said as of Monday, we've got new owners. So, I mean, a lot of the hospitals are looking at ways to diversify their services. One hospital is looking at funding for an entire new replacement facility. But in our final report that we issue, we're going to discuss a lot of these changes that we are seeing in this critical access market. We did send out evaluations to the critical access hospitals, the 16 who did participate in this project. These are some exact quotes from them. We've enjoyed the process. It was not overly burdened. It added great values. We got great benefits. We identified strengths and weaknesses. We're going to continue to use the tools. It enabled us to hold departments accountable. A lot of involvement from all areas of the hospital, and tracking these measures allowed us to hold employees accountable like we've never been able to do before. So that is pretty much where we did. Like I said, I had to go through that very rapidly, but I think it was a great project, and the hospitals did really get a lot out of it because we were definitely holding them accountable.
Thank you, Patsy. Thanks for all those great examples and feedback. Are there any questions for Sarah and Rhonda from Kansas, or Patsy? I'm sorry, not Patsy, Cindy Dupree from Georgia, representing the Georgia State Office for a Health Flex Program project. And you can put those in the chat box or press *2 to unmute your line. Okay. So I think this last slide that Nicole's pulling up are a few resources that we identified for financial improvement, and some of these I hope are familiar to you. Just a reminder about them. A guide to financing strategies for hospitals, and that's a 2014 document which does include some specifics on critical access hospitals. The Critical Access Hospital Finance 101 manual, and that is updated annually in terms of the indicators from the Flex monitoring team, but is a great resource with new administrators, CEOs, or for those administrators to use with their board of directors on how cost-based reimbursement works, and the basics and financials of the financial indicators report from FNT, and this is a link to the state reports. Of course, the individual hospital reports are not on the public site, but there are state reports, and you can compare all the indicators to national benchmarks. And then the Health Education Learning Program webinar playbacks and guides from the Small Rural Hospital Transitions Program, and prior to that, the RHPI Delta Program. There's over 75 webinars and guides, and probably at least a third of those are specifically in the financial improvement area, operational, and this link goes right to those financial ones. And there are some new resources coming out, as we noted at the beginning of the call, the COB Finance Leadership videos that we're having produced. And I know Rural Health Value, which is also supported by the Federal Office of Rural Health Policy, they're working on some new tools of projections for CH reimbursement in the future. With that, we'll wrap up today's call, and all of the presentations are online. There will be an assessment coming out. We appreciate your feedback on the content and format of the